morning, everybody. It's an honor and a proud privilege today to be speaking on the 47th birth anniversary of Jaslok Hospital. Before I start, I would like to dedicate this presentation to the victors and victims of this dreaded disease. Our truest inspiration, our fuel, our sole purpose. Hapless faces that look intrusively with gleaming hope into a pair of eyes peering from inside a COVID suit. None other than our brave patients for whom we all toil. The intensive care management of COVID consists of two arms, and both of them must go hand in hand for the management to be successful. The first, as we all know, is organ support. It's often been undermined in a lot of the literature and a lot of the discussions, and therefore I'm mentioning this first. We all know COVID can affect virtually every organ of the body. It's multi-systemic. Its main target is the pulmonary system. The cardiac, renal, neurological, hepatic manifestations of COVID are well known to all. And the second arm, of course, is the use of drugs. When we talk of organ support, we have a well-designed protocol which has been in place that our team follows, and I would be happy to share it with anyone, but I would not be able to share it in detail for want of time. So typically looking at whether the patient has low oxygen requirement, might have hypoxemia, we will start awake proning or put the patient on oxygen support. When the oxygen requirement increases, a lot of our patients are encouraged to be on HFNC, high frequency nasal cannula, with which they can comfortably lie prone as well, so they get the dual benefit. And of course, if we see worsening hypoxemia and they need a little more PEEP, or there is increased work of breathing, we prefer to put them on non-invasive ventilation. There was a lot of speculation at the beginning of the pandemic about using these modes for fear of aerosolization, but increasingly world over, this has been overcome. And as you will see, we've done great work using these two modalities. Of course, when the patient has severe respiratory failure and we see worsening tachycardia, tachypnea, accessory muscle use, we now don't shy away from intubating the patients early. Contrary to previous reports which came in early March and April, it's now believed that early intubation, a quick in and quick out, really helps these patients, as you would see in the slides to follow. And there was also a lot of speculation in proning these patients, mainly with the use of manpower. But I'm proud to say, with the support of our management, getting our manpower back, we have been able to prone a good percentage, nearly 40 to 50% of our patients, with fantastic results. The second arm, which everybody talks about, of course, is the use of drugs. And here I would like to tell you that the drugs are mainly classified into two broad categories, virucidal and anti-inflammatory, and of course other drugs which have a role in the management of COVID. When we talk about drugs which attack the virus, it includes CQS, which was probably the first drug to be flagged off because it reduces viral replication. Ivermectin, a humble beginning in a small third world country of Bangladesh, but now there's a great study from Florida, almost 300 patients, retrospective nonetheless, but showing a mortality benefit with an inexpensive, easily available, and relatively free of adverse effects drug. The much talked about remdesivir, also very talked about because of its availability, which was an issue. Now it's freely available, and it's also entered the guidelines of the ICMR and the American Society. But a word of caution here, remdesivir, by being virucidal, the existing data shows its benefit only in moderate patients, and in severe patients, all that it does is it reduces the time to viral clearance. That means the swab negative. However, it does not have any clinical hard points. So when I look at a clinician, my endpoint here is discharge of a patient. My endpoint here is extubation. My endpoint is getting off organ support, for which we don't have data for remdesivir. Of course, the data would be evolving soon. A word of caution that remdesivir also has a unique interaction with a lot of medications by virtue of being both hepatotoxic as well as nephrotoxic, since it carries a cytodextrin carrier. So you have to be extremely careful in selecting your population, and its benefit lies mainly in the first 10 days of the illness, where, as you will see in the subsequent slides, the viral replication is the problem. Again, another emerging therapy is convalescent plasma. I say emerging because like remdesivir, the data for convalescent plasma presently is only in moderate illness. I think a big plus point for convalescent plasma is the great community feel that it brings, because COVID has got our planet together, has got the human race together, and it's a great feeling for somebody who's recovered from COVID to be able to donate plasma to help somebody else. It really makes you feel enabled as a human being. I think that presently is the biggest plus point of convalescent plasma. We will see what the data shows us. Presently, it's very sparse. The other end of the spectrum is battling the cytokines, the hyperinflammatory phase, where we have steroids, which are again a cheap, easily available drug, have been used for time immemorial. And we did start our battle with COVID using steroids. And a few months later, we now have robust evidence to back that. We were using methylprednisolone. There is evidence for dexamethasone, but we don't think it's molecule specific. We think it's class specific effect, because steroids have been working well for our patients. In a dose of 40 milligrams, IV 12 hourly for 3 to 5 days, we use methylprednisolone. And for the patients who have prolonged hypoxemia lasting longer than 10 days, we would like to continue steroids for a longer period of time. There is also a role for tocilizumab. However, a big word of caution here. We've not had great experiences at Jaslok with tocilizumab. We use it on a couple of our patients, and in the 5 patients that we use it, only 1 has got discharged. 4 didn't make it, even though we very carefully selected our population, having burnt our fingers with the first patient who rapidly developed sepsis. We make sure blood cultures are clear. IL-6 levels are more than 10 to 15 times elevated, and the proctal is normal. But even despite that, we've not had great results. Again, an expensive, difficult to procure drug, maybe another Zygris in the making. We used also use Cytosol absorption therapies in the form of phosphorus and Cytosol. And even though these are non-specific as opposed to tocilizumab, which is IL-6 specific, we have actually seen more encouraging results for these therapies. A huge data says that there is microvascular thrombosis in COVID, and hence there's a role for anticoagulation, at least prophylactic. And there is varying guidelines to say that at a D dimer above 5,000 or some say above 10,000, we should proceed to therapeutic doses from prophylactic doses. And also in the population where there's a documented DVT or patients who have evidence of myocarditis in the form of arrhythmias, elevated cardiac markers, or antiproBNP. Now, I put this slide here for us to understand where these drugs fall into place. So the first 10 days of COVID, like I said, is a viral response phase where the viral replication is the main problem. And probably if you want to use any of your antivirals, which include remdesivir, convalescent plasma, or drugs targeting the virus, which is ivermectin or HCQS. And no matter what the data says, our own personal experience with both HCQS and ivermectin have been great. We've been using it, HCQS, right from the beginning of the pandemic. It's only in the second week, around the 9th or 10th day, that the host inflammatory response starts. And around post day 10, the host inflammatory response takes over. I put this slide here because we need to understand that there is not much of overlap of these phases. And we've seen a lot of patients, unfortunately, who are literally given this cocktail of tocilizumab and with remdesivir. I hope this slide makes it clear to you that where tocilizumab and steroids act is far away from where remdesivir will act. So if you're past the 10th day of the illness, there is little role of giving remdesivir. Maybe HCQS would still work because it has an anti-inflammatory action, but there is no role of combining tocilizumab and remdesivir, or tocilizumab, giving tocilizumab or steroids in the very early phase of the illness. You would only enhance viral replication here and probably call for a disaster in the form of uninvited sepsis. I put this slide back here again because very often we focus so much on the drugs that we forget that the cardinal point of COVID is organ support. And like I said, we've had a lot of patients who come to us loaded with drugs in the very first 4 or 5 days, and then transfer to our unit. This is the pattern in the last 1 month. Transfer to our unit with hypoxemic respiratory failure, tachycardic, almost like passing the buck that, okay, we've given all the drugs, now you do the organ support. Now that's something which will not work, and I'll tell you why. My favorite part of the presentation, On 18th March 2020, 3 young women and 2 young men fearlessly walked into the COVID unit of Jaslok Hospital, leaving aside small differences, leaving aside big responsibilities, resting on their tender shoulders. Since then, we have serviced about 280 to 300 patients in a service which started with 2 critical care beds, which expanded to 8, and we now have 13 critical care beds servicing these patients. Out of these 280 odd patients, 155, and I say 280 because what Mr. Harian has mentioned includes the patients admitted. I try to exclude those, at least the ward patients. So out of these 280 patients, 155 had severe COVID, required some kind of respiratory or pulmonary support. Of these, 119 were discharged to home. 10 are still in ICU and 26 expired. Our survival, ladies and gentlemen, in severe COVID in the last 4 months has been 79.8%, a data which humbles us as well. Of these 119 severe disease, 86 patients were critical. When I say critical, I mean patients who required some kind of organ support, whether it was form of inotropes, dialysis therapy, or HFNC or non-invasive ventilation, in addition to oxygen and bromide. 4 of these patients were deemed to not resuscitate. And yes, we are in an unusual era. They were children of these patients who said that we would have allowed our parents to just stay at home, but because they could not be allowed by BMC to aerosolize, they were just brought to the hospital to allow a slow death away from their loved ones. I've kept these 4 outside the analysis. I'm sorry for the typo. 58 of the 82 survived, which means 69% of our critically ill patients were discharged. Of these 84, 49 patients were ventilated. Out of these 49, 6 are currently in ICU on ventilator. 18 have survived to discharge. And 42% of our ventilator patients today have gone home. There's nothing that gives us more happiness than looking through this figure. And I'm really grateful to the management, Dr. Patrak and Dr. Desai, for suggesting that I talk about this, because that's one thing which made me dig up this data and look at how we were doing. Looking at the age-wise survival, so we've looked at patients under 30, and we've had patients all the way up to the age of 95. Our youngest patient was 95 years old. We had 2 patients in the plus 90 category, and at both extremes of age, we had 100% survival. Quite congruent with the rest of the data, in 31 to 40 years, we've had 94.7% survival. As you can see, the highest mortality has been in the age group of 71 to 80, and the next closest is 61 to 70, quite in keeping with the world data. Somehow I think the people who cross 90 probably have it in them. They have superior genes from another generation, and so they have defeated the virus. Looking at world data, a few studies. So a few studies from North America. One suggested that 67% of their severe illnesses, severe COVID died. 24 remained critical at the time of writing the paper, and only 9.5% were discharged to date. Another study from Lombardy showed 26% patients died. At the time of writing the paper, 58% were in ICU, and 16% of the critical patients were discharged. Data from Wuhan, China, the epicenter where it all started. 62% of these patients were critically ill. 62% of the critically ill died, and 21% of the ventilated patients were discharged. We now move home to our little city, Mumbai, and that's the hospital that we all love so much. We've done pretty well. 32% of our critical patients died. 68% of our critical patients discharged, and 42% of our patients who were ventilated have been discharged to date. We have done a lot of learning. We've had a heads up over the past few months from a lot of these countries. But this data is definitely encouraging. And I think the data calls out to all our young and brave residents. who started off, like I said, as a team of 5, who overcame a lot of personal barriers. And it's lovely to see how the COVID warrior family has expanded. We've had some of our consultants who put their hands up to come and give a lending hand to our registrars when they've been overworked. We've had a young father who left his baby, 3-month-old baby, to come back and work from another city. We've had a little girl who got married, but abandoned her holiday, came back to work, and numerous such stories. Another young man who never went home to see his child with meningitis because he thought his work here was more important and there would be a pediatrician who would look after his child. There are numerous such stories which I would probably not even know about. But all that I know is that here is a generation that has left its teachers inspired forever. Thank you everyone for your attention.